able to get a copy of the amended outline, of course. Today is the first time we have an outside speaker, and before I introduce him, the procedure, according to your outline, will be to have Dr. Madison go first, and then feel free, unless he contradicts me, to raise any, do you mind the issues being raised as we go along, Don, or you want them raised at the end of your presentation?
As we go along with this.
Okay. Then at any point you care to interrupt as you go along, please do so. And at the end of approximately an hour, we'll try to switch over so we get on to the materials that are more along the lines of the Roma reading and clinic staffing and the kinds of things that we did there. But the grounding that Dr. Madison is going to give us in the physician end of it is the beginning point. Now, Dr. Madison is a member of the Social and Administrative, full professor in Social and Administrative Medicine, and a long-term student of all matters related to physician careers, curriculum in med schools, rural practice, and one of the pioneers in the early neighborhood health center movement, Appalachian clinics, and that kind of thing.
Okay, I'm going to use the blackboard some, just jot down some things. This will be a kind of a elementary gross anatomy lesson in medical practice, which is about what we can do in an hour, I think. And anytime you have a question or desire a clarification or have a comment, I want you to interrupt me. Please do that. How to begin? I guess the best way to begin is to contrast the present state with in the United States with what things were like 40 years ago, before World War II. Then about 70% of medical practice, 70 to 75% of medical practice, would have meant general practice. That is, by physicians who didn't confine themselves or even emphasize any particular specialty. Now, many of the rest weren't specialists in today's terms. They were simply general practitioners who, having collected a bunch of cases and maybe got a 6 months extra training or something, decided to limit their practice to something. But 70% or so were really generalists. The other big difference is that then 85%, about 85% of all medical practitioners were in solo practice. Now, the main things that have happened over the time since then is, number one, the trend towards specialization. Now, less than 25% of physicians are generalists and family physicians combined. It's hard really to know. You get conflicting figures on how many are not soloists, but somewhere between 20 and 30% of all physicians remain soloists in a pure sense. And the other main trend has been a tendency toward geographical consolidation of practice. That is, no longer, as was the norm 40 years ago, do the bulk of physicians practice in locations out in the community from where the bulk of their patients come from. They now tend to practice in their own neighborhoods. In some cities, that have hills and valleys. They practice on something popularly known as Pill Hill, next to about 3 or 4 hospitals in the same neighborhood, often in huge office complexes called professional arts buildings or medical arts buildings. And that's becoming the norm, and it wasn't the norm before. Now, the other thing that's happened is a tendency toward grouping of practice. Grouping. And I use the term grouping rather than group practice because it's a better descriptor of what's happened. There is an official definition of group practice, which if you haven't already had, you will. And if you won't, you will right now. I'll read it to you. This is a precise and exclusionary definition that the American Medical Association has set forth. And the importance of it is that the only counts of group practice come via the American Medical Association. So this definition is the standard for what gets counted as group practice. Group medical practice is the application of medical services by 3 or more physicians, formally organized to provide medical care, consultation, diagnosis, and/or treatment through the joint use of equipment and personnel, comma, and with the income from medical practice distributed in accordance with methods previously determined by members of the group. So you can see that it not only has a functional component to it, it also has a exclusionary political component. The American Medical Association favors the idea that the doctors who practice in a place should themselves determine how income is to be distributed, and says that group practice is only that, and thus excludes a lot of practices that in every other way would be groups, such as, for example, the UNC Student Health Service. To give an example, is 200 yards from here, because those physicians fulfill all the qualifications of the definition, except that they themselves don't decide how the income will be distributed, do they? That's decided by someone else. But the tendency toward grouping is far more than formal group practice. Now, I'm going to try to set down a classification of practice for us. Before I do that, let me mention some ways in which medical practice is classified, might be classified, in order to make a point. First of all, by function. What does the practice do? How do you ask what the practice do? First way might be to ask the question, how many specialties are represented? 1, 2, 5, as many as there are, what? Which ones? What levels of care are represented, does the group provide? Primary care only, and secondary, and tertiary, only secondary and tertiary? Another way to get at the question, what does the practice do? What's its function? Thirdly, who does it serve? The general population? Members of the armed services and their dependents? The poor? elderly people living in a retirement community, children, enrolled members of a prepaid plan. All of those are ways of getting at the question, what is the function of the practice? And you can then begin to classify different kinds of medical practices according to their function. Second way is to classify groups by size and complexity. How many physicians are on the staff? 1, 2, 7, 150? And in how many separate locations does the practice operate? Only 1, 2, or several? So we have terms like sole site versus network, solo versus group, etc. Ways of classifying practice in terms of size and complexity. The third way is to describe the environment of the practice, talking now about the physical geographical environment, and classify medical practice like that. Is it in, meaning essentially part of, a hospital? The term hospital-based is occasionally used to describe practice. Or if it isn't, is it located near a hospital? On the Pill Hill that I was describing earlier? Or is it out in the community? Is it situated in one of those large medical arts buildings? Or one of those small medical arts buildings down on Willow Drive in Chapel Hill? Or not, etc. What's its environment? Still another way to classify is in terms of organizational control, or who calls the shots. Is the practice private? Private for profit? If it is it owned by the physicians who practice there? Or by someone else? To all of the physicians who practice there, or only a few of them? Or is it part of a proprietary chain? Or is it a division of some industrial corporation? Or maybe it's organized as a non-profit entity, in which case perhaps it's part of a medical school or a hospital or a university health service. Or is it an independent, freestanding community organization with its own board of trustees? Or maybe it's a government agency, like part of a health department, or a military dispensary, or a prison clinic, and so on. Classifying groups by organizational control. Another way is classify them by their primary method of finance. Does the practice rely mostly on the fees it collects for services rendered? Or maybe it's financed primarily via a capitation-based contract with a prepayment plan. Or maybe it receives a budget appropriation. or a retainer? Or is it financed by some combination of all of those methods, or some of them? And if so, in what proportion? Another set of variables that can be manipulated and divided, and out of which can come yet another way of classifying medical groups. Finally, what's the legal organization? Is it organized as a solo proprietorship, or a partnership, or a professional corporation, or a professional association, or a nonprofit corporation, or a business corporation? Or is it a wholly owned subsidiary of some other organization? Or again, is it a public entity, meaning part of government? All of those are different legal forms answering the question, what does its charter say? Now, those are some of the ways in which it's possible to classify medical practices. There are only a few of many. There are several others. Now, obviously, what's most interesting to the doctors who work in the practice and who would tend to classify it according to those interests is not necessarily the same as what would be most interesting to a health services researcher, or a lawyer, or an administrator, or a government bureaucrat whose job is among other things regulated, or to an insurance company executive. And so that's probably the main reason, because when we use, when we refer to a practice as a, for example, a partnership, or a group, or a professional corporation, we're only describing one particular aspect of that organization according to one possible way of classifying it. And the multiplicity of ways to classify is probably the main reason why, while there is good data on physicians in the United States, there is such a paucity of data, good data on practice. It's very difficult to say, to look up in a book and find out how many of X variable under here there are, or X variable under here there are, because no one can agree on how they should be classified and how the data should be collected. So we count doctors instead of practice, which is the point of all this business. Now, before I move into the way of classifying that I'm going to put forward for discussion purposes, I want to set forth a few terms that will come into play. Some of them will. Also for clarification purposes. Private practice. What is private practice? What does it mean? Somebody answer.
I guess it can just be a physician that's in practice for himself, and he's not affiliated with a hospital or whatever. He either rents or owns office building.
Okay. Your response connotes a sex and it connotes a number.
Yes, reverse that.
Still connotes a number.
Or physicians.
Singular or plural. You said for himself, and you said something about ownership, did you not?
Right.
Or the med-first centers that the Humana corporations set up around the country, private practice. Like the one that's
Private, since they're proprietary, but, since they're looking through
they're private in terms of how they have to pay the taxes and the charter that they have and the recognition that's given by the government, but not in the sense of that. There are also large groups who are owned by some of the doctors who work there, but not all. So they might be private for those who own them. They can say, I'm in private practice in a group. But the physician employees might not think of themselves in the same way. That is, they might not describe themselves to their friends as being in private practice. They are, but they're not. It's partnership. As a form of practice, what does it mean?
At least 2 doctors together.
Anybody disagree? 2 doctors together.
At least
partnership.
2 or more.
2 or more together. What else? Anything?
Like the income and the responsibilities as far as the overhead and salary for office workers.
Sharing dollars in and out. Partnership has 2 definitions, both of which are used when describing medical practice. The first is a strictly legal definition. It means multiple proprietors. The exact meaning is defined by 50 laws in 50 different states. In other words, it's a legally authorized way of doing business. Partnership can be 2 physicians or it can be 150 physicians, as long as some multiple, more than one, are proprietors. The other meaning is an informal social meaning. Partners in a tennis doubles match, in a dance contest, in marriage, or in a work situation. And physicians often refer to partnership in that sense. In that sense, which may not fulfill the first definition at all. 2 physicians who are independent legally and financially may well share the office together. Keep everything separate except certain of their expenses, but they're in the same specialty and they cover for each other. And they refer to each other as my partner. Or they may be in practice together, jointly, but not be a legal partnership, and still refer to each other in the sense of the informal social partnership as my partner again. What else might they be in that case? Professional corporation is another legal term defined in the laws of every state that authorizes doctors to do business in that way.
Is that the same as professional association?
Essentially. Essentially. There is as much difference between professional corporation and professional association as there is between professional corporation in one state and professional corporation in the other state. Professional corporation is a means whereby a state law authorizes physicians to do business as corporations, and in so doing, realize some of the benefits that business corporations have from doing business like that. Most of which benefits are what kind?
Tax.
Tax. So when the tax laws change, it becomes more beneficial or less beneficial to do business as a professional corporation vis-a-vis a sole proprietorship or a partnership or a business corporation or any of the other possibilities that might be available to physicians in a given place.
And there's this concept of limited liability. How does that apply, if they were suing the doctor versus the corporation, their malpractice suit or something like that?
Well, malpractice can, I believe, be made against both the individual and the corporation, and usually this to cover all bases, and not expecting them to on both points of the suit, but I'm not sure. Professional corporation requires how many physicians? Private practice, professional corporation, solo practice, may be all the same thing or they may not be. Professional corporation in the for himself sense may not apply to all professional corporations. Depends on who ultimately runs the professional corporation. Likewise, solo practice is not necessarily private practice. And of course, it's not necessarily a professional corporation. The only thing that it isn't for sure is it's not a partnership. Okay, that's just a plethora of miscellaneous terms to attempt to clarify any possible misconceptions that you have. You seem to have very many. These are general terms, or they're specific, have specific purposes, especially the legal applications, and most of them are defined by the laws of a state. Okay. Now, I want now to put forth an outline of physician practice forms that I think is reasonably comprehensive, and you stop me if you can think of something when we're through it that doesn't fit in some way, and I'll revise it accordingly. Start out with what I call the simple forms. Now, this outline is going to be a combination of many of those ways of classifying that I put down earlier, plus some others. It draws a bit from sociology as well. The first one is small office practice, which there are 4 types by my classification. classification. The first one I call independent and isolated. Independent and isolated. The norm of 40 years ago. Still has plenty of examples in the United States, urban and rural, but probably the characteristic example of the independent, isolated form of small office practice would be the single doctor town. Single doctor rural town, which there remain a few, but there are some. That's to be contrasted with the second form, which is the colleague network. Now, the colleague network is a group of independent physicians who are geographically isolated one from the other to some degree, but they are dependent to a substantial degree on an informal network of colleagues. For example, it usually involves cooperative arrangements among independent physicians, such as shared call schedule, informal but definite consultation and referral patterns. And it usually depends on a common affiliation of all the colleagues with the community hospital. They're all on the staff of the same community hospital, and it's through that hospital and the membership on its staff that the informal connections that the network depends on become formed. The working relationships that have to happen between the physicians on small hospital staff, and it depends also on a certain amount of good faith. In fact, as often as not, it's the absence of good faith that makes the difference between one particular physician's membership in a colleague network and his retaining the old-fashioned, independent, isolated practice form. In other words, I'm not describing something that looks different. That if you're walking down the street, you can look at an office or look in the Yellow Pages and say, this is independent, isolated, this one is a member of the colleague network. It's not that kind of thing. It has nothing to do with size, except that we're talking about small categorically. It's a more sociological distinction. And you'll go in one community and find that the predominant form is this. You go in another community, and for historical and maybe personal reasons, the dominant form will be this. This. And you won't know that until you've nosed around a bit. But they are distinct in the way that the physicians behave, and in the kind of supports and satisfactions that they cherish or they can do without or whatever.
Just one question.
Yeah.
I'm picking up on where you're coming from, except the colleague network, I see like maybe a large rural area where these guys are separated, and you're talking about on-call, like a call type thing. They might call up Joe over one county over, or whatever, halfway across the county and say, hey, I need this done, or could you cover for me? Is that what you're talking about?
More than can you cover for me, it's more that we've already arranged that you will cover on every other Friday, and I will cover the other time, and so will cover on Thursday, etc.
What does the independent person then do? He just doesn't have any cover at all. I mean, he's always independent and isolated.
Always independent and isolated. and tends to avoid situations, clinical situations, where coverage would be absolutely necessary. He tends to be the physician who, in the day of hospital affiliations, does without one. Very good. Or doesn't take care of anything more complex than X level of complexity. Refers a lot. Stays close to the office. Third type, organizationally independent, but geographically dependent. This type is a colleague network of independent physicians, but it differs from what I'm calling the colleague network to the extent that all of these physicians are located within the same place and are dependent upon their location for additional cooperative arrangements that go beyond this, that are a function of their geography. They share the same buildings, and as such share the rent perhaps, share a receptionist or more. Seldom goes as far as records, but it may go to a receptionist and telephones and so on. It may even go to the billing service. It most certainly in larger buildings will go to, they kind of agree informally that there will be one radiologist suite in the building, and all of them will send the radiology referrals to that particular radiologist, as opposed to the one 6 blocks down Pill Hill Lane, and so on. More than that, typically in these buildings, they will have a formal or informal rule that says, when and if a suite becomes vacant, we would like to fill that with X kind of physician, meaning the kind of physician that we don't have, or that just left, or that we've been wishing we had for a long time. We will not fill it with variety X that's already represented in our organization, independent, geographically independent network practice. Okay? So I'm talking here about essentially the professional arts, the medical arts building.
Is there sharing of income in such a situation? I don't see.
Virtually never. Virtually never.
What's the incentive of getting a particular type of doctor in your building? If they're going to refer to someone else?
Competition. They want someone who, first of all, isn't going to compete with somebody that's already there, so it's a kind of self-protective informal guild. And that's the main thing. From that, usually as a function of getting to know someone that's fairly adjacent, lines of referral will usually develop, and that new physician can sort of count on, since he gets known, the other people in the building to become a source of referrals. Not exclusively, but more than would be the case if it were just another position in town in a different geographical location. Okay? Fourth type is the organizationally dependent form of small office practice. Where the small office practice, irrespective of location, is dependent On a larger organization, typically I'm talking about the branch clinic of a hospital or a larger group practice. Or some other organization. Where the backup, budgetary management, probably referral lines as well, all go back to a larger, more complex organization. Of which small office practice setting is a subset.
So what, okay. So they're actually, people are coming to see them and they're saying, well, we're sending them to the hospital. And they're doing what they can do, or they can't. So when they're referring to the hospital, that's the kind of the lines or whatever you're talking about. But in turn, they get some sort of support, you say, or budget.
They're part of the larger organization, so for good or bad, the larger organization runs things ultimately. They're not independent organization. They may be organizationally, clinically, virtually independent, but they're not organizational administratively. Now, another type of simple practice is single specialty group practice. Going to the AMA's definition of 3 or more full-time positions, et cetera, excluding the last clause. Single specialty group practice may at the same time be itself part of a colleague network, be itself part of a medical arts building, or be itself an organizationally dependent small practice setting. It would, by definition, not be independent and isolated by virtue of the fact that we're talking about a group that has multiple positions there already. Now, all of this, I should hasten to add, and should have in the beginning, is a classification of primary care practice forms. There are practice forms that apply to pathology or neurosurgery that are somewhat different from this, and I think don't matter as much to you since the proportion of ambulatory care in the practices is much smaller.
Excuse me.
Yeah.
It seems like all of these except the number one are physicians in some kind of relationship with other physicians. Can you tell me, or do you have any idea of which one of these would be more, I guess, politically powerful in, say, a community? Have you observed any data that would give you an indication of which of these would be more politically powerful?
No, I think you can make a case.
It depends on the situation.
Community variables are so much greater than the organization variables. Single specialty groups. Single specialty groups in the United States average about 4-point-something positions. The larger single specialty groups tend to be the non-primary care specialties. Anesthesiology, radiology, for example, which means that of the primary care single specialty groups, they tend to be closer to the minimum number. Remember, this is all coming from the AMA data. closer to 3. Take out the ones that tend to be larger, and the average comes down below 4, whatever average is. When a single specialty group in internal medicine, and to a smaller extent pediatrics, becomes larger toward 8, 9, 10, 11, 12, it tends to organize itself away from primary care. That is, the reason why it would want to become larger would be to divide the labor up according to the subspecialties of internal medicine. We have an endocrinologist, now we need a lung person, and we need another cardiologist, and next we need an oncologist and a hematologist, etc. And therefore, that's another reason why the need for the primary care single specialty groups tends to go down. As they get larger, even within primary care specialties, they tend to lose their primary care. Okay? That's the end of the classification of the simple practice forms. In contrast with these simple practice forms, which tend to be physician-dominated, that is, the physician, the individual practicing physician is the important element in the small single specialty group as well as all of the others. The complex forms are organization-dominated. An organization dominates. First one. Fee-for-service, multi-specialty. Fee-for-service, multi-specialty. There are approximately 3,000 multi-specialty groups in the United States, and they average about 10 physicians each. Multi-specialty means simply more than one, but the vast majority of those 3,000 also have more than 2. And we're talking about 10 full-time physicians typically. Now, fee-for-service multi-specialty group come in 2 varieties. First is the Noah's Ark variety. Noah's Ark multi-specialty groups are Mayo Clinic imitators. The Mayo Clinic, which it wasn't formed, it evolved, but became known as the Mayo Clinic somewhere around 1890 and won its national fame probably sometime within the next 20 years. The history is not very definite about when the Mayo Clinic came into national ascendancy. Set the pattern for the multi-specialty group specialty referral model. In which a group would be set up to be the backup for all the general practitioners, which at that time, with the Mayo Clinic, constituted 95% of all physicians. They were diagnostic referral centers. And Mayo quickly became a training ground for specialty physicians. And because it became a training ground, and because it had great regional influence in the upper Midwest, it spawned a lot of imitators. And in all of the states surrounding the Mayo Clinic, bordering on Minnesota, and toward the southeast as far as Illinois and Indiana, which aren't states that border on Minnesota, but they're in the same general region. There are a disproportionate today number of multi-specialty fee-for-service groups, and there are many around the country, but they're disproportionately located in those areas. And they all date from before World War II, sometime, usually in the 20s. And most of them, in one way or another, began as Mayo Clinic imitators because some founder had some connection with the Mayo Clinic, typically a surgeon who trained there. And what they wanted to be were multi-specialty, specialty referral models for the areas around them. And in order to do so, they tried to collect one or two of every then-known specialty. And Richard Weinerman, talking about this, gave them the title of Noah's Ark model of multi-specialty group for that reason, the way they were staffed. As the generalists began to disappear and be replaced by specialists who opened practice detached from multi-specialty groups, their original reason for being all of these groups all around the United States became less salient. And they tried to pick up by providing primary care as well as as trying to retain some of their referral patterns that they began. But trying to be a primary care practice from a Noah's Ark staffing pattern is one thing. Trying to be one from a primary care-based staffing pattern is another, and an easier one. And trying to turn Noah's Ark into primary care-based is not easy to do until everybody finally retires, who represented a lot of the top-heavy staff in specialty areas. There are, however, other groups that sprang up with the later as primary care-based multi-specialty groups, fee-for-service groups. Obviously, there's a never land between the two, and you look at one group and you might have a difficult time deciding which one it is. But on a spectrum, you can certainly say that it is not as far to one side as another, and more, which still enables one to speak of it in this way. Prepaid group practice, as opposed to fee-for-service multi-specialty group practice, is, first of all, like fee-for-service, is always multi-specialty. But unlike fee-for-service multi-specialty group, is always formed, always invariably formed, on a primary care staffing base. For obvious reasons, you know what they are, right? Anybody that needs that explained? Okay. Then there's hospital-based primary ambulatory care, which essentially is of two types, and you begin to see some more here how I'm mixing in all those different means of classifying practice. Physician-owned and/or operated, and hospital-sponsored. This type is most typical in certain rural communities that sometime in history those towns were the site of where some Mayo Clinic imitator wanted to do his thing. Established a multi-specialty group, if not in the beginning, then later, located it on the hospital campus or across the street, and became the only game in town, and is de facto hospital-based, even though organizationally independent. And that kind of situation can be found in a number of places around the country, scattered. Gallipolis, Ohio, Elkins, West Virginia, Tarboro, North Carolina, Danville, Pennsylvania, Marshfield, Wisconsin, go on and on, named about 5 others that I'm familiar with, and expect to find, if I was really looking, 20 or 30 others, I'm sure. Hospital-sponsored ambulatory care might be multi-specialty group practice or single specialty group practice, and more is becoming that. But traditionally, I'm not spending any time on this because you've already covered it well. Of 2 types: the emergency department and the organized outpatient department. Finally, there's another classification under the complex organization comment, and that is the corporate model, by which I mean these chain 7-Eleven types of immediate care things that are run by investor corporation, public businesses, and there are variations which haven't been developed yet, but there's all kinds of reasons for them to do. One more subclassification, a major one, still under the organizational dominance, but varying from all of these, I call primary care programs with special missions. They're a category that I won't go into except to mention. I guess this is nearly 35 categorical programs. Programs that are not set up to provide general primary medical care, but do so within limitations as a byproduct of caring for the category of problem that they were set up to take care of. To a greater or lesser extent. Health department categorical clinics are the main example. Industrial clinics in large plants would be another example. You can look at it. I'm 9 minutes past 3, Mike. Do you have any comments or
Can you give a good example of that the elderly feeding? You said there's an example of really quick.
of the what, I'm sorry?
The one you said that had the elderly population served by a conference.
Yeah, there are large retirement communities built by big developers in Florida. Rossmore in New Jersey. You've driven up the New Jersey Turnpike toward New York, Philadelphia. You've seen it, some big globe there. Remember, up on the right. There's one in Seal Beach, California that I know about. There's Sun City, Arizona. These are large sort of levitt towns for older people who made enough money to afford to buy in and live there in a retirement community among other older people. And in so doing, they bought not only lawn mowing service and shuffleboard courts and gyms and movies and all that, but they've also bought access to a group of physicians who set up just a circuit. There aren't a lot of them, but there would be undoubtedly as many as there are these complex, large complex retirement communities.
I guess there is no such existing setup in Asheville.
Not that I know of, that I don't know. Anything else? Okay.
Thank you again, Norm. Appreciate you. Would you all like to take a 5-minute break now and reassemble so we can do the rest of the discussion, or how would you like to do it today? That suit everybody? Why don't we try to get back a little over 5? I'm just discussing that till everybody gets back in. This one's going to take a little more time to give out these readings and explain them to you. So let me start it in a few sections. At this stage, I'm still providing the readings, but coming up will be the text. It'll just be that much shorter, okay? How about where you know somebody's sitting in a seat, putting them out at for them and passing them on.
Can we get to ask you a question about some of that stuff?
You sure can. When we start up again, we'll get on any of that that you feel is, I felt like there was some of it you all might have had more questions on, or it was a reflection of the complexity that we talked about earlier. I'm just sending them up that way. I didn't send enough, did I, for that in? One more? Okay.
Sorry.
Now, if you'll just keep these clipped together as they are, they're in several sections. I'm going to start them around, okay? These is going to be about 3 sets of clipped together stuff this time, maybe 4.
Take one and pass it down.
Yeah, that's right. It says pull them in their paper clips if you don't mind. These really, let's put down with this. And this, if you get any extras at that end, why, pass them back. I may have passed too many out of some of these. Final thing is a single sheet. Put them on there. Then I want to talk to you about them in the order that I sent them around in, so you understand what you've got to hold on. These are the extras, okay. First thing I sent around was a thing that's the top of it is the cup, how big, okay?
There's
What do you,
one we're both missing.
well, you're missing which one?
The second one I came.
Called panel, you have this
No,
one?
we have that one.
You don't have the one with the big foldovers?
Correct, yeah.
Okay.
Just two of us.
You need 2 of them, okay. Fine.
Oh, and she doesn't have one, you need three.
You need another foldover? Okay, this one. If I talk to you about them a few minutes, you'll have an idea of what you've gotten a hold of, okay? I'm trying to give you a variety of materials, both textual and current, and it'll give you some background. You need a set, excuse me. And the first thing I sent around is a thing that has a thing called a cup. How big? Let me just talk about that a minute, what's in there. Of course, you have to turn it over to realize that's a cup. That first cup didn't reproduce. And what we've got there is 4 pages of very important graphic materials that I think by finding it takes the place of some cases 5, 6 chapters of some of the text you've been reading. I mean, it gets to the bone of it very fast, okay? What it's all about, and it's extremely well done, even though it's most recent. It's used in the most recent year in 81. I think you'll each find in your places a selection. And the one we're using is first reading, if you'll sort through, that we're taking a look at, is for next time. It's called The Cup. Okay? That's 2 pages. It's 4 sides. And those graphics are extremely good at breaking apart what third-party payment is all about, okay? And it does it for the last full year in this 81 Perspective magazine analysis with the graphics I thought are the best I've seen of that doing it. Then there's another few pages. There are quite a few, more than last time, from Wilson and Newhouse. They're called Paying for Care. I take a chapter which I chopped off most of the tables on. It's only the ending tables I left on. But there is a problem. If you'll turn it over to the very back now, cup to the back, the reproduction of table 5-4 at the top, you see it there, the last page, you're looking at the back. It lacks some words you need to fill in to understand what it's saying. National health expenditures by type of expenditures. See, expenditure, the last part of it's there, comma. Amounts, comma, per capita is what's missing, amount. Okay, that's what's missing. And then it goes on percentage distributed. It's also page 124. Came off of that. Okay, but it's otherwise runs from 99 to 124. I told you one reason for using Wilson and Newhouse sometimes is it's an 82 text, and it therefore is offering the very latest comparisons through 79, whatever, the very latest year that broke this stuff down. It also has a simplistic way to it, and the other stuff may be more complicated, but I think it's important for you to, what you got there then is the payment stuff. You got it? That first section we've been going over was payment. Remember, the speaker is the expert in this state who happens to be one of the real experts in Medicaid nationally, okay? Therefore, to take the focus off on the Medicaid before you've got a, assumed background in payment, it's just one minor sector, much more minor in the total framework, say, than Medicare, let alone private pay, okay? Now let's look at the rest of the readings and look at them in the following order. First, a very early hearing. See, shows you it's a congressional hearing page, okay? You got it? And it has a huge foldover I worked on to get you. What I'm trying to do there is give you an early version. I'm making no effort here at current events, okay? This is to show you how early the law was passed in 65. It took effect in the middle of 66. The Medicare, Medicaid laws, see those hearings? And those 3 pages of text and those tables, if you'll look at them, begin to give you the most clear sense of what's happened to the inflation that they're screaming about today, okay? It happened right at the beginning because the AMA lost the battle, but it won the war. And you're going to see it all right there, very quick, okay? If you can't read those tables, it means you don't understand that Congress thought the price of, say, hemorrhoidectomy was $50. That same carrier began immediately on the passage of Medicare paying $131 as usual and customary. They totally turned around the congressional words, you see, right from the very beginning. And you can see the outrage of Congress on the shortest dated, 69 hearings. This was published in 70 with the hearings finishing in 69. All they had was 67, 60. They only had about 1.5 fiscal years, and they're already seeing the same carrier who will not pay more than $112 for something suddenly pays out of Medicare. You see, in the same state, $350. You'll see it there, and if it doesn't give you some sense of outrage, in other words, for the same people to be now screaming, it doesn't know what it's doing and it's not bankrupting when they were the ones that lobbied it to get like this. He wanted to give it to you historically, very early, how it all got off. Otherwise, you're going to get distorted with the picture. In other words, between getting the idea of how many dollars there are, okay, and where they are out of that other stuff, then getting an idea of how early Medicaid took off. Now we're on to the last two things. This pinned together says, panel says most states failed policing Medicaid fraud. It would be a mistake to get off on fraud. But what I've given you first is that story, and then two terribly dramatic life stories of terrible corruption, unequaled corruption in my book, charted, deliberately charted on the calendar. Turn over that first woman. That woman's trying to become a singer. She's dead at 31. Turn that page over and look at the back, what's tacked to it on the back of that fold over. Turn over her face now and look at the last month of her life and see they've got charted how many prescriptions and what those doctors poured into her and what they billed Medicaid for to kill her, okay? And it shows like death after death. These investigative reporters really do a beautiful study of nothing short of the utmost corruption possible. The next feature story called Take It and turn over again past her face to the back. You're looking at the doctor that did it all, his corrupt criminal record. His criminal record is detailed, even though he's paid the money. And the drugstore, which ran up from $30,000 a year to $562,000 in annual billings to Medicaid, okay? Medicaid alone. In other words, it would be a big mistake to be hitting Barbara and Matula with this stuff, but let's get an idea of what they're faced with, okay? Fraud is not the issue, but you got to be aware of it, okay? Because it's Phi Beta Kappa people, always in my book, and not real crooks. You can catch a real crook. It's Phi Beta Kappas you got to keep your eye on. And the university's full of them, okay? So let's look at the editorial. The editorial is not crooked. It's full of sweetness and light. It's the latest issue of the AMA News, right? January 21. It's as current as you can get. Read it, please, and tell me if, how constructive the AMA is in 83, right? About all these problems. Now they're going to pitch in and help, aren't they? Read it carefully. Turn it over and just see a simple ad from a little mountain weekly newspaper, that doesn't go into writing big words, right? They just tell the people they've got some federal funds. If you're unemployed, come on in. They got a sliding fee scale that's in effect, and get services, right? Then go back and try to compare. And you use your wits about you politically. This is the AMA's best editorial you're going to see, okay? There are significant problems. Isn't that serious? I mean, if you think they're talking about the crooks you've been reading about, you're very mistaken. You're going to see what they're talking about, okay? They've got to really get going now. They don't have enough lobbyists, okay? All right, you got the idea? So it isn't for you to go home and ask Barbara Matula, why doesn't she take care of the crooks? Her problem is, the crooks may be already on her advisory council and above her in the structure, okay? I'm telling you about it so you get the idea of how bad it is, okay? But I'm warning you, as I'm going to say to her, is if she doesn't get the idea, I'm giving the reading to give her a hard time why she runs a crooked program and pays crooks, or anyone else pays in Michigan or anywhere else to kill people. My purpose is not that at all. It's probably to say that the only reason we know it is because Congress can ask questions about Medicare and Medicaid. And let me ask you if you think you can ask any questions of Blue Cross Blue Shield. Anybody here believe they can? Biggest? Anyone ever seen their A-frame glass palace out on the road to Durham? Y'all seen it? Okay. I mean, try going in there and ask questions. Try going in and ask him how much double billing it is a year by any doctor. What is his name, what they ever did about him. What letter they ever wrote to a medical society to get somebody expelled, for double billing. You see what I mean? I ask them how many doctors are on their board, how many hospital administrators, you know. These are the real issues. And that's, I don't want to mislead you on payment. We don't want to get distracted by the fact that all bureaucrats are exposed. They're out there like public health nurses, you know, you can watch what they're doing. It's in private that the real dollars are passed around, okay? Anyone need any warnings about the fact that I have very particular views you have to be on guard against? So you form your own views, and I've already been asked, can we now continue the discussion? I gave out the readings for a particular reason, since two people have lives, they have to leave early so they wouldn't be late getting these. This is a lot of reading. It's fast moving, it's dramatic. You're less than human if you're going to be able to put down parts of it, okay? There's something very seriously wrong with you, because the medical students come to me for extra copies. I mean, they've never seen, they're not handed anything like it inside the med school. You see, when I use it, like I use the 2 Detroit stories on what they call the underclass now, you know, to show they got an idea there's a new underclass. We got all new sociological jargon for everything, you know, the new people that are permanently unemployed from generation to generation. And to show them, you know, look, this is what the underclass is faced with. You know, these kind of people loosen their communities, you know, and you go read it and see if you have any, you know, what your feelings are like. For the rest of it, you better learn it. You better learn about payment of care, and you better learn what you can about why these programs got off to this kind of start, why I'm giving you this early Medicare hearing, just a few pages, you know, make up your own mind. Here it is, tabula, in the first year and a half of Medicare, and just see who turned it loose. Who amended the law so that Social Security could not police the doctors, and made the amendment very simple. All that would exist between Social Security's dollars and the provider would be what? What will be in the middle? You know, all these laws have something in the middle. What do they have? What's the word?
What did you say?
What exists in both these laws? What exists in Medicare, the biggest payer, right? Medicare.
Between the doctors and the...
Between Social Security Administration, the original Medicare law said they would pay the MDs, right? They would pay the hospitals, like the UNC fund does. They were modeling it on things, right? You can police them when you do that, can't you? You can't get paid for that. You're a crook. You follow me? What did they simply put in here? Both laws. That's right. You all got the word? What is it? So for hospitals, they've stuck in a fiscal intermediary. Nice word, right? Social Security can only read the reports of the fiscal intermediary and try to detect fraud inside that report. Very hard thing to do. They sit on the board of it, right? Okay? The Blue Cross is controlled by hospital administrators, right? Now, the doctors, it gets even nitty-gritty. What did they put in between there? Carriers. Just different words, you know. They put carriers.
It's really funny, you know, it's really hard to do this, but I mean, I've seen these things. I've gone over to Blue Cross and tried to get cost reports and such and such.
You try to find out what's going on, yeah.
Bring the guy some flowers and some stuff. And
You try to find any way, because I've been in this position of direct payment for several years. When you're in direct payment, if you think Blue Cross doesn't know what I know, or Blue Shield doesn't know what I know, or the insurance carrier don't know what I know, how many crooks they're on, and what county they are, you're mistaken. It's that they will not tell anybody, okay? They're like the girls who assist, isn't that terrible? The men surgeons in the OR, and to say, or they're the male orderlies who assist in the OR, the new women surgeons, okay? Their mouths are shut. And so it's very hard to find out that Dr. A really operated on the left knee when the orders were clearly there was a broken kneecap on the right knee, right? Until the parents can find that out and sue for malpractice, it's just too bad. Whatever explanation you make stands. Okay, let's go back now, without all that scandal, to Dr. Madison's nice, calm, surgical. He said it was an anatomy lesson, was it? What questions, Miss McAllister, might you start off with? Any of that you,
Yeah, there was something I was confused about, his definitions of the difference between private practice and solo practice and professional corporations. I'm still not clear about what the difference between them, or whether they're all the same thing.
yeah. What about that? Could they all be the same thing? She just stated. Did you hear the three categories? Could a thing called private practice, now let's follow this, be categorized that way? Then come over here as between solo and group, and you'd say, yes, it's solo. And now come over here between partnerships and all these other things and say it's a corporation too. Could it be all three? What's the answer on table? And how many think it could be all three? How many think it's impossible in any way for it to be all three? Any missing link? See, it could be one doctor in that independent way he described him, not even in colleagueship, not even networking, and still form a corporation for... did somebody answer when he asked that? I think I heard the answer. What reason usually do they become a corporation? Tax benefits, okay. In other words, he can set aside up to 25% of his income tax-free, you know. He has other advantages too, you know. The corporation board of his wife and his three 4-year-old children, triplets, both to send them to Hawaii to a medical meeting and tell him to get a first-class ticket, which he trades in, then takes his wife and the children free, and they go, and all that. The IRS spends hours on the minutes of these corporations just auditing them. Okay, because the children are not old enough to vote, you understand, so their Aunt Beth had to take a trip from California to cast their votes at the board meeting. You ought to read in the Wall Street Journal to read about all the things that what the tax court has. There's that short tax court summaries sometimes of cases they throw out, and they're out of fantasy land as to what these doctors try to get away with.
Well, you're also talking about sort of speaking criminals, regular tax, stating that they were honest and pure.
You think there's some honest confusion in that board?
What's that?
Were you saying there was some honest confusion?
No, I'm saying that when you're talking about the doctors, that when you bring in a tax court official, it's basically the guys in the tax court, the tax measures get there for being honest and pure and wholesome.
I think the point that you're making, Ms. McAllister, is extremely important, and I want to remind you of what we said originally. It's going to be very disturbing to all of you that the complexity in ambulatory care and the mix and the overlapping, I remember I warned you a couple of times, I'm going to keep warning you, it can be very annoying. It's not anatomy. He's using the word anatomy, but you know, to get it straight, anatomy is after all you can memorize the 167 bones in the ankle or whatever doctors and nurses have to do. You know, and idiot things like that. There's none of this over here, okay? A hospital is not a complex organization. They'll call it that, okay? It is as military, you know, is it hard to understand an Army regiment? I mean, the people that have very limited non-Jeffersonian views of the world go to West Point and can learn how to organize a regiment or an infantry battalion or anything. After all, it is exactly this many tanks. It's exactly this many, you know, everything falls into line. When it gets a little bit slippery, did you all read it in Romer that there are 3 categories, remember? Anyone want to throw out some of the names of them, of what kind of ways of outpatient services the hospital deliver from some of the readings I gave you last time? Call that, what kinds?
General.
What?
General.
General, there's general. There's general PD. Okay? Outpatient part. What other kind of emergency. Well, these we tend to call ERs now in smaller towns, right? Because that may be all. And there's one third category he uses in this report. Yeah. Would one of you, Ms. Proctor, perhaps tell me, what do you think referred is? Because that is the least simple one, its title can be misleading. What gets referred into a hospital that's not going into a larger, usually an urban hospital, so outpatient, appointment time clinics?
I think that is patients who are seen by private physicians who are referred for some sort of specialized
Yeah, that's exactly right. It's because the hospital has either special personnel and/or what? Equipment. Example, CAT scan, right? So that this is fast growing, right? Because of that reason, not because the word referral means referral, like in England, from the storefront general practitioner to the hospital specialist, okay? They are really not using anybody in the hospital except a reader, a respiratory specialist who's going to read a, chest spirometry that he doesn't have in his office, okay? Which is the most common of all these? Which is the least common? Go at it that way. If there are 7,100 hospitals in this country, where might they be less than 50%? In which category might they be less than 50%? General, that's right, Ms. Harris, yeah. The reason is we're talking about larger urban, usually up here. Right? You don't, many small towns have a scheduled pediatric baby clinic. You don't have these things except what did this take the place of historically? What was the old dispensaries, the free dispensaries for the poor, you see, that kind of thing. This is very common. There's still millions of these visits, a year, etc. This is very common because it's become what, essentially? It's much less emergency than primary care on an out-of-hours basis, right? Referred services because of this new business. There's more and more equipment on it. So it was helpful breakdown, but the words were strange. You follow me? We wouldn't think of this, as a outpatient service. It's that he at least broke them apart for us, remember, in the Roma readings that you had. What's going on? He gave us some data in the Roma readings which showed that really the AHA, the American Hospital Association, only began counting some of this stuff in 1965. And the very latest year before he closed off his 82 book was 77. Well, there's some very sharp rises in that stuff in those 12 years, and that was just 12 years. Huh? Would you all say they were terribly high rising? Which one grew the least again? Yeah, somebody say general? Yeah, general grew the least. That makes sense too, you see. It's the ER services, how are they? Remember, money flows. Do a lot of insurance policies cover them?
Yes.
Yeah. The referred things are likely to be covered, right? There were some other reasons why the ER grew. Can any of you think historically of a piece of legislation that caused very structured ERs to move very rapidly in this period?
Weren't they required to provide services to you regardless of whether you could pay or not?
Well, you're thinking of the Hill-Burton. Hill-Burton, I'm not thinking of. Hill-Burton could affect inpatient as much as outpatient, as I remember it. I'm thinking more of why the ERs opened up in hospitals where they'd never opened before. What other thing happened that we would consider under ambulatory care service, under a broad definition? The whole EMS legislation, you remember it? Was about 10 or 15 years ago, and it stated in it huge grants could come from the federal government to any state that had a plan, and that plan had to state where you were taking them. Well, if you didn't have ERs, you follow me? And they funded a lot. You see, in that anytime you got money coming out, right? Medical education grows, things grow. It was one of the growth factors in the whole, ER development that we see. Hospitals that would not have tried. Another thing in the Romer stuff, does anyone want to bring it up to date. He had a study in here as to how you staffed ERs. You remember that? So over on, remember I pasted this up so bad you can't hardly find the pages on anything, because I'd cut them off in my little pasting job. But it's really in the middle of on the right-hand page as you're looking at it, not on the back, called Type of Emergency Medical Staffing is his table. And what does he say in there? What percentage were staffed by full-timers? What was the biggest percentage in staffing those? What kind of, how did they staff them?
Rotation of attending students.
All right, now what does that mean? Does somebody want to define that for us? Ms. Cohen, what do they mean when they say that 65% of all of these in time of his survey?
That people who are on the medical staff in the hospital
Okay.
take turns.
They take turns. All right, that was very typical in what year? That he gave the year of the data. Because I would say that is way off today, huh? Yeah, the latest, there was no 80, you see, thing out in AHA. The last time AHA, a lot of people, again, did you notice Dr. Madison is supporting us and as a real textbook expert? The chapter in Noble's textbook is by he and Ned Brooks. You know, you'll find him in chapter after chapter, you know, on physician organization, on rural care, on, you know, career choices by physicians. You remember he's repeatedly stating, like the AMA knows a lot about doctors and can offer you almost no data, you know, about groups. You follow me? That what you're asking could be well defined. I felt like asking, but I'll ask him privately, is he sure that because they defined it narrowly, they necessarily ruled out the doctors who hadn't themselves decided? You know, we'd have to talk to the people who compiled the data in Chicago at the AMA headquarters. They could well have thought it through and said that if they accepted jobs on salary that other people set, we're counting them in it because, in effect, if they didn't set it themselves, they bought in. You know what I mean? Yet you never know what the data means. They don't define it clearly. You see, a lot of the definitions in this area are blurry. And all that tells you is there's a revolution going on. It has been going on. You see, there's no central body. There's no AHA is supposed to have command of things, you see. The minute it moves away from beds, if you want to pick up a copy of the American Hospitals, you all look at it, their journal, you'll be able to find out as of 3 months ago or 2 months ago exactly 62.48% of occupancy rate. They're just like airlines. They can announce within 30 days on where their dollars flow on inpatient care. You will not find this. You'll find what I told you, that ER visits started their first decline, you know, since they've been keeping statistics in 82. Outside of that, this kind of breakdown that Romer's giving, you notice how he has to give it from different statistics, say it doesn't exist. He can't compare apples with oranges. He jumps his years sometimes and all of that. What I would say is this. My experience is that 65% is very much lower today, and what's taken the place of it is the California type of corporation, wherever it comes from, Raleigh. In other words, corporations either owned by other people or owned by some doctors or employing other doctors, but corporate entities are furnishing. In any recent survey, I don't know do any of you work in hospitals or agree with that this is the most prevalent thing I see moving in. The hospitals I know where what Ms. Cohen described, you know, where everybody, there are 32 people on the staff, they got it divided up so that, you know, each of them takes one night a week and they only take a weekend so many, you know, every third month or whatever the system is pretty much in decline, is fast falling and replaced by the specialized emergency room coverage. What we're doing then is reviewing a number of staffing problems. There's one staffing change. Do you all agree, or do you have other observations from any towns you know of about this development? That's in ERs. We're all in agreement that I think that I don't see very much of general clinics. Do any of you see them around? Does Raleigh have them? I don't know where. They do exist. cities the size of Raleigh. They exist in Greensboro, don't they? I think in Asheville. The largest cities of this state have them. Do they exist in the smaller ones that anyone here knows? They're not a typical, pattern. Would you think they would grow? I would think not. There's a buck to be made in private, corporate, Now he put up on the, anyone want to comment on some of the other Romer stuff here? He went into home care a little, satellite ambulatory. You remember that appeared in Dr. Madison's thing under primary care. He belatedly said the first whole group he was discussing, do you remember that, was all primary care. I think you all have that clearly in your mind, that it could have been confusing if for any reason you were beginning to wonder where were single specialties other than family practice or peds, or internal medicine, because there were some, you would think of big groups immediately if you hadn't ruled that out in numbers, There are, people that band together in much larger groups, single and multi-specialty. What about the clinic staffing now? Let's discuss that a while and go around the table a little on it and get some of your... Is there a possibility that through groups we can staff either outpatients and things in the hospitals or non-profit freestanding clinics in a more efficient way in ratios and all of support staff? And what are the things that would go towards efficiency? What elements are there of either proximity, geography, or anything else that lead to greater efficiencies that you all can think of? All right. Look, we're talking about staffing. You're going to staff anything, okay? It's possible first to say there are deficiencies, there are weaknesses, there are disadvantages, say in hospital ERs and hospital even general clinics, okay? Or in freestanding ones. Let's try with somebody advocating, maybe saying some points that might be advantages, or if someone's on the other side starting out with some disadvantages. Go ahead. Or dealing with both.
I've done doing clinical rotation in the Tennessee way at one center.
Okay.
And some of the problems that I see, they staff their general clinics with residents mostly. And there are some attending physicians who are generally on this part of the school of medicine here that do the work.
Okay.
And that seems to me extremely inefficient because the residents rotate through every 2 weeks. So you get a lot of times getting these clinic schedules, the fact that there are so many different ones, I think makes for a really inefficient use of time in terms of for patients because there's no continuity. They have to review in the greater depth. Nobody knows the patient. He's kind of come even though he's been there 50 times.
Leaving out patient satisfaction and patient quality, which are interfered with, right, by the lack of continuity, even in efficiency. They just don't know the patient. They have to read this whole thick chart, to grasp what the current problem is. You follow me? They run scared. They're residents. They don't want to make a mistake. They don't want someone to say they missed something, So that's an item of inefficiency by the nature of the staffing. There's a statistic I'd like to throw into it. Do you remember in the Romer stuff when he was talking about organized clinic visits, the general clinics? Well, a part that you didn't read here, I'd like you to have it when that occurs, I think, on his page 56, opposite 57, that's in numbers on the Romer readings. You remember where he's showing the growth of organized clinics over there on 56 in that table? I wanted you to have a number, that there's one more thing I don't think that appears there. In the last year for which the AHA checked university medical center teaching affiliations, of that number of organized clinic visits, 8% of the institutions had teaching affiliations, but they delivered 53% of all those clinic visits that you see in that table. See, and that's not shown there. You notice what he's breaking it down by who owns the sponsorship of the hospital, you see? If we're all looking at the same table. But a more significant figure to me is, and it relates to what was just said, you know, by Ms. Proctor, namely that there's quite a discrepancy, you know, where you got teaching affiliations, that's where over half of all these organized clinic visits come. We've already said on another matter, the emergency visits above, where larger numbers are concerned, they're likely to be using, you know, will they be using residents sometimes in ERs? Yes. You all know, don't you know of places where residents moonlight? That's not an uncommon mode either, you know. It may be the second most common mode nowadays, but the doctors usually on the staff are in a downswing, as I see it. So the first point's been made is a deficiency when you use residents based on pure efficiency. How slow they have to be, you know, and how cumbersome, and how the patients back up over it. All right, what other advantage or disadvantage when they're operating like this in a group? Remember, this is all forms of groups as well as ambulatory modes, right? This is not separate, simple practice. The isolated person or in a network that he first described, remember those 4 categories? We're talking about all these hospital-based settings being a type of group setting, okay? But compared to other things, do you see advantages? Can anybody tell me advantages that you might see?
One thing, you've just got a mere increase in numbers of available warm bodies to see whatever patients go through.
Very important. The hospital is full of warm bodies that can have multi-use. In other words, the fact that a woman is assigned to the emergency room and nothing is going on in it right now, or 4 of them are, and one can hold the fort until they ring a bell, can release 3 of them to go over here to something else, okay? It is the multi-use of personnel that a hospital can make or an institution can make. Another advantage is the availability of space. We do not have to create a new unit, you know, freestanding or otherwise. Usually, in efficiency terms, you know, if inpatients by definition take up 24-hour, 7-day use of the beds, if there's full occupancy, it's the outpatient side, if you have wings of it closed that are, you know, if you close certain hours that are, or there is space available, that's unfortunate, you know. The biggest deficiency I see is the one that you'll have to see all the time, is that the people who run hospitals are interested in what primarily? Profit in proprietary, or what the non-voluntaries would say, operating in the black. But where does that come from? Where is their hearts and where are their minds? On the inpatients. So all of this always gets the tail end of the dog. That's the problem. See, in planning and the brain power in the hospital, at the say we comprise the morning administrative staff meeting at Rex or at Columbia Presbyterian or anywhere, okay? So now Miss Proctor or Miss Young speaks up. Miss Young, you speak up. You tell us some of the things that you think should be done outpatient. You're in charge of outpatient. How boldly should we move into it? You think this meets any need we ought to be dealing with this morning? What would you suggest in what a hospital ought to be doing? This is a hospital staff here right now. You got any ideas what could be done in any kind of ambulatory thing? Give us a real pitch. Make a statement of some firm sort.
I think that we should strive to contain outpatient visits.
Are you meaning admissions or the troubling thing, or the most costly thing? We're being criticized for that. And you're saying that we ought to get a higher ratio of outpatients, of ambulatory things?
No,
Or what?
you should reduce outpatient.
Reduce outpatient. What's your reason for reasoning that way?
Well, there are a number of doctors that are complaining that Monday through Thursday, the outpatient department is crammed with patients.
Okay, you hold that, that's excellent, but there must be somebody else at this table that's representing ambulatory that wants to speak to this point. Who is it? Anybody think we ought to go in another direction? Where should the hospital be standing? Anybody want to speak to it? There's a bunch of doctors complaining about Monday through Thursday, there's too many outpatient visits, okay? What do you think, Ms. Harris?
Well, I was going to take the standpoint that in looking at numbers, we can process more people through the clinics than can be seen on an average hospital stay, whereas on the floor there may be 40 patients that can be seen by a group of physicians covering the patients on that floor. And
Do I hear that you're making a pitch for some way expanding our ambulatory services here?
Additional people to see more patients, additional physicians, additional residents.
Now, if we put very much, you think you're going to need some people to study this then, Ms. Harris, this problem?
Probably, especially when it comes to looking at how many additional support people we need.
Yeah, so we're going to have to spend some money now to study this, are we? Is it worth spending money, you think, for this area?
I think if you look at the average cost you can get per patient that comes in, can we drain $200 per patient per day by getting into, labs and x-rays and whatever it can be. Hospitals.
Now, we've got these 860 beds, and they're only 62% filled, and they are the biggest drain we've got in this institution. They are costing us.
If we start a strategy to demarket the clinics from people who don't have insurance and screen for people who do have insurance, we want to make sure that we use the outpatient clinics as feeders and to fill up our empty beds. Then the clinic becomes...
Oh, now you're saying the problem in those, what Ms. Young raised is probably a lot of Medicaid people and a lot of deadbeats, maybe some transients.
You wanted to argue.
Huh?
You wanted to
That's
argue.
right. We want to get the thing rolling here now, right? Now, we're going to demarket them. That's a new phrase to me, but does that suit everybody? We're going to now get rid of these people if we can. How are we going to do that and keep our PR stance? This is Columbia Presbyterian. We've got some very moral ministers on the board and other do-gooders. What are we going to do about this? Because we've got to make this place pay off. How are we going to go about demarketing them?
Well, I just thought of something different. Why don't we've got, this alcohol clinic over here that would gladly pay us for 24-hour use of, say, 50 beds. Why don't we open up a wing to them? And that way we'll have 50 beds with constant money coming in, whether they're filled or not. And we can have options to fill those beds if they're not filled.
We're real lucky. You mean the man has not cut the alcohol program? That's one uncut program. Well, I'm glad to hear that. Okay. We've got one place we might sell some of the beds to you, all right? What else can we do about our problem?
Who are we? Are we in hospital?
Yeah, well, we're obviously on drugs ourselves because we're off in every direction. We didn't start out role-playing by determining that you were an advocate of this or that.
Well, if I'm a hospital administrator,
Go ahead.
I'm going to do it this way, but if I'm not, which I generally tend to think is like...
Okay, you're going to talk a different way.
We're saving the outpatient, we're boosting outpatient care.
Well, all right. Yeah, we had no givens. We were trying to get something started. What I was trying to say, and I think maybe some of you agree, it was disclosed a little bit, but only a little bit. If we had each had roles to play and talked the thing out, okay, you would have found that with most of you concerned, one of you concerned with inpatient nursing services, okay? One concerned with a business office, okay, if we had really done this on a role-playing basis. One concerned with medical records and a whole host of backup services. Another concerned with x-ray lab and so forth. And only one person speaking as typical, on a hospital staff for the satellite offices that are losing money out there, one of them at Siler City and one somewhere else, you know, and for the ER and for the, you know, few clinics we're operating, and everybody else somehow caught up in, right? And we forgot there'll be at least a fiscal vice president sitting there and a budgetary officer probably, right? You end up usually, by my saying the tail end of the dog is that Miss Young may have already been in such a meeting because she came in like the tail end of the dog. I mean, she acted like this meeting's going to whip her little tail if she didn't come in here, saying that from Monday to Thursday we're already in trouble down in these clinics. I mean, that is the mood. If you don't believe it, you follow me, that you learn not to speak up too loud when the hospital's about to go bankrupt over occupancy, except with inventions like Miss Harris turned up. You know, if you suddenly are a genius and can invent a way to fill more beds, then they love you, okay? But for the rest of it, you would have to follow a pretty brutal policy, I think, as Mr. Yao enunciated. Now, some of you might want to now, that I've given some more sharper viewpoints, now dissent or agree or do what you want to do.
I think it's very interesting because, you know, when the new state Medicaid plan came into effect, along with most of the teaching hospitals, the ones that provide so much care, that was a big thing. I mean, those outpatient departments take in a lot of Medicaid, and when they cut down, the state saying cut your Medicaid usage to Duke and then to Memorial. At the same time, the AHEC people are saying, what are you talking about? We got interns, we got residents here, we got to learn this stuff, and this is where they learn. They hack on these poor souls over here. And so there were the competing things right there. So if you didn't have the teaching going on, you know, a lot of the outpatient would have really been cut out.
Well, why is 8%? 8% of all the general clinics are seeing 53% of all the general clinic patients. All those millions of visits of that one category. Why? I mean, what, are they good do-gooders? Universities are do-gooders?
Souls they practice.
Huh?
They need the people for teaching.
Absolutely, and that we're being very kind. They need to practice on them, right? Most of us that practice on a piano, we can tell we're making an awful job of it in our first year or two. But when they put them in their grave, remember, the grave never speaks back. I mean, they have practiced on them, okay?
The other side of that, though, is that some of the patients have nowhere else to go.
All right.
And they look to the teaching centers like Memorial and Wade as their only source of care. And they can't go anywhere else if they come over to the Wade outpatient department. Because if they go to Rex for care, they're going to get sent away. You know, there's nowhere else.
All right. Do we agree with that? This is a very important point, that many patients have nowhere else to turn for an appointment type of clinic where an internist hopefully might spend some time with them. And you stand a chance of getting an attending, or at Memorial you stand a chance of getting a faculty member. You know, besides a resident, your odds are lower, but you know, somewhere your chances are in there, aren't they? And there are people with very satisfactory relationships, you know, with university teaching stuff. What should the person in charge of that be like? What should be the characteristics of an administrator of an ambulatory care clinic? Should he or she just attend this kind of meeting? That's their administrative side. Are there any human characteristics? Is there anything lacking in amenities or anything about these places that...
I think more and more places are becoming more sensitive. You know, I was reading this article, some of the description of some of the waiting rooms being unattractive and that sort of thing. In most places, I don't think are like that anymore. Not maybe in some areas. That there is more sensitivity to the patient's needs. I think there's still the problem of scheduling a lot of people to come at the same time, and that's true in private doctors' offices too.
But is it more true in where you're teaching, is it not more true?
It's certainly, yeah, I'm sure it takes longer to see them because, you know, if a student has to see the patient and the attending has to come see them and then they both go in together, I mean, you know, it does take up a long period of time to do more waiting.
What, you're shaking your head, Miss Young.
Well, my experience at the VA over the summer was that it stayed so crowded in the outpatient department that the residents and interns were actually triaging the patients while they were sitting there in the waiting room. And I don't think there was much sense to be there for the patients.
I don't know about
Is the quality of the care usually pretty good once it's rendered? Is it not probably above what might be out there in private practice?
It depends on where you are, I think, but I know at Wake, you get a heck of a lot more time spent with you than you do if you
Yeah.
be a doctor. Because I've worked with physicians in
Mhm.
private practice who used to carry a timer, so you make sure that, and it would go off after 10 minutes, so you make sure that you finish that window with the next patient. Whereas with, now that's an extreme example, but in a clinic, it's not unusual, once the patient gets in there, to spend an hour or an hour and a half with them just to reach a visit. But that's not.
Can we all around this table agree that the odds are that you probably will not get worse quality and you might get better quality? Anyone want to disagree with that? The quality. Now, the humanity with which you treat it. What about that? You were speaking with a positive vein. I just want to go around the table. It's like looking at race relations. You know, everything's relative, right? Somebody's saying compared to 25 years ago, they're immensely better, okay? On the other hand, is there anything about, and you spoke to the humanity, okay? Suppose I were to tell you, let me be the devil's advocate. It's my permanent role anyway, so. Are you all on warning? That's the only thing I have to keep saying so that, you know, before they throw me off both faculties is everybody's on warning. I always figure you can't corrupt people that are on absolute warning about their morals and everything else going to go to hell encountering me. Let me describe Chapel Hill to you, Med Center, okay? In the opposite of what Miss Adams just did. I regard it as the worst rural slum I have ever seen, regardless of the intentions of whoever's in charge. Okay, I don't even know who's in charge. Maybe if I met him, I'd like him, you know, so it's a side one. They have built a med center not in downtown New York City or in San Francisco where land is at a premium, right? They have built a monster. It opened in the fall of 1952. And for some odd reason, Wing D, which was then the nurses' dorm, continues to function for psychiatry, for hand surgery, for rehabilitation of hand surgery, with patients. Let me ask you, we bring a consultant along. What was the first thing you said on seeing the ramp they built? That any aid, I mean, you don't know what architect designed.
Get a wheelchair, it goes up and around square and
Go look at the end of Wing
like
D
a box.
where they
You
have to
cannot
bring in
possibly
badly
get a
burned
wheelchair.
patients. And there are, 4 90-degree turns to be made in a 3-foot, this kind of radius, okay?
There's just no room.
Then think of the people coming in there, right? They're on their 4th hand surgery in rehabilitation, right? You've got all these expensive standby people. Psychologists waiting to see them, physical therapists, waiting to see them, surgeons waiting to schedule the next surgery. They're in there for rehab, and I've been in that building, and they had a wheelchair had to be picked up and carried in bodily the steps until these geniuses designed this ramp about 2 years ago, and then they finished it. And it comes in, and it goes up, and it turns here, and it comes back, and it comes in, and it goes in. Now they're on a level, right? And go look at it. It's at the end of Wing D. But isn't the whole place a rural slum? I mean, who ever heard of so many buildings? Even if when you get in, how does the patient get through this mess? I'm making a devil's advocate position the other way of why a multi-story parking garage that is inadequate, they're going to build it higher. Why? Why did they build it out in the country? What's wrong with Disney World? I mean, why don't they learn anything? That they could have an electric rail, you know, just circling the goddamn thing and announcing for less money, you know, like it does in the Atlanta airport, you know what I mean, without even a driver, right, going, for less money than the multi-story is going to cost them. Or what's wrong with the poor people in Carver getting a job to drive little buses all day and night and get you in there, huh? I mean, just think of the idiocy. When are aides ever consulted? When are maintenance people ever asked, will this work?